In the sterile corridors of military medicine, where rank determines respect and experience commands authority, a young woman in surgical scrubs was about to shatter every assumption about what it means to save lives under pressure. She had no military background, no combat experience, and certainly no reason to expect that within 18 months, the highest-ranking Marine general in the Pacific would stand before a room full of decorated officers and call her the most remarkable doctor he had ever witnessed in action. What happened between her first nervous day at the Naval Medical Center and that extraordinary moment would challenge everything the military thought it knew about courage, skill, and the true meaning of service. This is the story of Dr. Sarah Chen, the civilian emergency physician who became a legend not through battlefield heroics, but through something far more powerful: the unwavering determination to save every life that came through her doors, no matter the cost to herself. Sometimes the most extraordinary stories begin in the most ordinary ways. Sometimes legends are born not in moments of planned glory, but in the split-second decisions made when everything goes wrong. And sometimes, the person who changes everything is the one nobody saw coming. Dr. Sarah Chen adjusted her white coat for the 5th time as she walked through the automatic doors of Naval Medical Center, Portsmouth. The morning sun cast long shadows across the military facility, and she could feel the weight of hundreds of eyes following her movements. At 29, she looked even younger, with her slight frame and nervous habit of tucking loose strands of black hair behind her ear. The security guard barely glanced at her credentials before waving her through, probably assuming she was another medical student or nursing resident. She had spent the previous night rehearsing introductions in her apartment mirror, trying to project confidence she did not feel. 2 years of emergency medicine residency at Johns Hopkins had prepared her for trauma, chaos, and life-or-death decisions, but nothing had prepared her for this moment. She was about to become the youngest civilian emergency physician ever hired at one of the Navy's most prestigious medical facilities. The hallway stretched endlessly before her, lined with portraits of distinguished naval officers and medical personnel who had served with honor for decades. Their stern faces seemed to question her presence. What was a civilian doing here among these heroes? Sarah quickened her pace, her soft-soled shoes squeaking against the polished linoleum floor. Dr. Michael Rodriguez, the chief of emergency medicine, was waiting for her at the nurses' station. He was a bear of a man with graying temples and the kind of weathered hands that spoke of countless procedures performed under pressure. His uniform was immaculate, every medal and ribbon perfectly aligned. When he saw Sarah approaching, his expression remained neutral, professional, but she caught the slight tightening around his eyes. "Dr. Chen, welcome to Portsmouth Naval Medical Center," he said, extending his hand. His grip was firm, testing. "I trust you found the facility without difficulty?" "Yes, sir. Thank you for this opportunity," Sarah replied, meeting his gaze despite the flutter of anxiety in her stomach. She had practiced this moment, but the reality felt overwhelming. "Let me be direct with you, Doctor," Rodriguez said, lowering his voice as he led her away from the bustling nurses' station. When the hospital administration decided to hire a civilian for this position, there was significant discussion among the medical staff. "This facility has operated with military physicians for over 70 years. Many of my colleagues questioned whether someone without military experience could understand the unique demands of treating our patients." Sarah felt her cheeks flush, but she kept her voice steady. "I understand their concerns, sir. I'm here to prove that civilian training, particularly in urban emergency medicine, can complement military medical expertise." Dr. Rodriguez studied her for a moment, then nodded slowly. "Your credentials are impressive. Johns Hopkins emergency residency, top of your class, published research on trauma management. But credentials mean little when you have a helicopter full of wounded Marines landing in 20 minutes and every second counts." He gestured toward the emergency department's main floor, where a team of nurses was checking equipment and supplies. The organized efficiency was beautiful to watch, every movement purposeful, every piece of equipment in its designated place. "Your first week will be orientation and shadow shifts," Rodriguez continued. "You'll observe our protocols, learn our systems, and understand how military medicine differs from civilian practice. The patients you'll see here are not just victims of accidents or illness. Many are returning from combat zones, dealing with trauma that extends far beyond their physical injuries." Sarah nodded, absorbing every word. She had read extensively about combat medicine and PTSD, but academic knowledge felt inadequate in this environment, where the stakes were measured in human lives and military careers. Dr. Walker will be your supervising physician during orientation, Rodriguez said, indicating a tall woman in her 40s approaching them. Dr. Jennifer Walker moved with the confident stride of someone accustomed to command. Her blonde hair was pulled back in a regulation bun, and her uniform bore the insignia of a Navy commander. Dr. Chen, I presume? Walker said, offering a crisp handshake. I've reviewed your file. Impressive academic record, though I notice you have no military experience whatsoever. That's correct, ma'am, Sarah replied. But I've worked extensively in urban trauma centers, including 6 months in Detroit's emergency departments during medical school. Walker's eyebrows rose slightly. Urban trauma is certainly valuable experience. However, military patients present unique challenges. These are individuals trained to endure pain, to follow orders without question, and to minimize their injuries even when severely hurt. Reading their actual condition requires different skills. Sarah felt the first stirring of her competitive nature, the same drive that had pushed her through medical school and residency. I understand, Commander Walker. I'm here to learn those skills and contribute whatever experience I can offer. The tour began immediately. Walker led Sarah through the emergency department's various sections, explaining the layout and functionality of each area. The trauma bays were larger than those in civilian hospitals, equipped with specialized equipment for treating blast injuries and gunshot wounds. The psychiatric evaluation rooms were designed with safety features Sarah had never seen before: reinforced walls, minimal furniture that could be used as weapons, and discrete monitoring systems. Military patients often mask psychological trauma behind physical complaints, Walker explained as they passed the triage area. A Marine complaining of headaches might actually be dealing with traumatic brain injury from an IED explosion. A sailor reporting stomach pain could be experiencing severe anxiety about returning to sea duty. Learning to see beyond the presenting symptoms is crucial. Sarah absorbed everything, taking mental notes and asking occasional questions. The other medical staff they encountered were polite but distant. She could feel them evaluating her, wondering if this civilian newcomer would measure up to their standards. The first real test came sooner than expected. They were completing the tour when the emergency department's alert system activated. A helicopter was incoming with multiple casualties from a training exercise accident. Sarah's pulse quickened as she watched the medical team spring into action. Stay close and observe, Walker instructed. Do not intervene unless specifically asked. The helicopter's rotor wash filled the landing area as the aircraft settled onto the designated pad. Sarah watched through the window as Navy corpsmen rushed toward the aircraft with stretchers. The organized chaos reminded her of her residency trauma rotations, but the uniforms and military precision added an intensity she had never experienced. 3 patients were brought in rapidly. The first was a young Marine with an obvious compound fracture of his left arm. The second was unconscious, with suspected head trauma. The third was walking but clearly in shock, blood seeping through bandages on his torso. Dr. D. Gordon. Rodriguez took charge of the unconscious patient while Walker moved to assess the walking wounded. Sarah found herself positioned near the Marine with the compound fracture. She could see immediately that the break was severe, with bone fragments visible through the torn skin. The young man's face was pale, but he was gritting his teeth and refusing pain medication. I'm fine, Doc, he kept repeating. Take care of the others first. I can wait. Sarah recognized the signs of significant blood loss and early shock, but the patient's military training was causing him to minimize his condition. She glanced at Walker, who was busy with her own patient, then back at the injured Marine. His blood pressure was dropping, and she could see that the fracture was affecting his circulation. Marine, what's your name? She asked quietly, moving closer to his stretcher. Corporal Martinez, ma'am. He replied, his voice strained despite his attempts to appear strong. Corporal Martinez, I need you to let us help you, Sarah said, her voice gentle but firm. Your injury is more serious than you realize, and waiting could cause permanent damage to your arm. The corporal looked at her with confusion. Who are you, ma'am? I don't recognize your uniform. I'm Dr. Chen, and I'm not military, Sarah replied honestly. But I am a doctor, and I can see that you need immediate attention. Martinez's eyes widened slightly. He had never encountered a civilian physician in a military medical facility. The novelty of the situation seemed to cut through his trained stoicism. Sarah seized the moment. "Corporal, your training teaches you to put others first, and that's admirable. But right now, following medical orders is just as important as following any other orders. I'm ordering you to let us treat your pain and stabilize your injury." The approach worked. Martinez nodded and allowed the nursing staff to begin an IV and administer pain medication. Sarah carefully examined the fracture, noting the damage to surrounding tissue and vessels. She knew this patient needed immediate surgical intervention. Walker appeared at her shoulder. "Observations, Dr. Chen?" "Compound fracture of the radius and ulna with vascular compromise," Sarah reported. "He needs orthopedic surgery immediately, and I'm concerned about compartment syndrome developing." Walker examined the patient herself, then nodded approvingly. "Correct assessment. Good work getting him to accept treatment. Many civilian physicians struggle with military patients' tendency to minimize their conditions." The next several hours passed in a blur of activity. Sarah observed multiple cases, each presenting unique challenges that required understanding military culture and psychology as much as medical knowledge. She watched Walker handle a Navy pilot who was terrified of being grounded due to a minor injury, a Marine sergeant who refused to admit he was experiencing panic attacks, and a young sailor dealing with homesickness so severe it was manifesting as physical symptoms. By the end of her first day, Sarah felt mentally and emotionally exhausted. The complexity of military medicine went far beyond anything she had studied or experienced. These patients carried the weight of service, duty, and sacrifice in ways that affected every aspect of their medical care. As she prepared to leave, Dr. Rodriguez approached her. "How was your first day?" Dr. Nancy Peratos says that 17 men had 4 eyes. "Chen?" "Challenging," Sarah replied honestly. "I have a lot to learn about military patients and culture." "That's the right attitude," Rodriguez said. "Too many civilian consultants we've worked with came in assuming their experience translated directly. You seem to understand that this is a different environment requiring different skills." Sarah nodded, feeling a small sense of accomplishment. "I want to be worthy of the trust you've placed in me, sir. Tomorrow, you'll begin taking cases under supervision," Rodriguez continued. "Start with minor injuries and work your way up. The staff is watching you, Dr. Chen. Some are hoping you'll succeed, others are waiting for you to fail. Either way, you'll need to prove yourself through your actions, not your credentials." As Sarah walked to her car that evening, she reflected on the day's events. The portraits in the hallway no longer seemed as intimidating. She was beginning to understand that she was not just treating medical conditions, she was caring for individuals who had dedicated their lives to serving others. The responsibility felt enormous, but for the first time since arriving at Portsmouth Naval Medical Center, she felt ready to meet the challenge. 3 weeks into her tenure at Portsmouth Naval Medical Center, Sarah had fallen into a routine that felt increasingly comfortable. Her supervised cases had gone well, and she was beginning to understand the subtle differences between military and civilian patients. The nursing staff had warmed to her, appreciating her willingness to listen and learn rather than impose civilian protocols on military medicine. But routine has a way of vanishing without warning in emergency medicine, and Sarah's first real test arrived at 2:47 a.m. on a Tuesday night in October. The call came in as a mass casualty event, a phrase that sent adrenaline coursing through every medical professional in the facility. A Navy destroyer had experienced an explosion in its engine room during night training exercises. Initial reports indicated multiple casualties with severe burns, smoke inhalation, and possible blast injuries. The ship was racing back to port, but several patients were in critical condition. Sarah had been alone in the emergency department during the quiet overnight hours, handling minor injuries and routine cases under Dr. Coppell, Walker's remote supervision. Walker was home but on call and could be reached by phone for any serious cases. The 2 other emergency physicians on staff were handling their own assignments in different parts of the hospital. When the mass casualty alert sounded, Sarah felt her heart rate spike. She had trained for situations like this during residency, but never as the primary physician responsible for coordinating care. The nursing supervisor, Chief Petty Officer Maria Santos, appeared at her side immediately. "Dr. Chen, we have 6 incoming casualties, ETA 15 minutes, Santos reported. Dr. Tuel, Walker is en route, but she won't arrive until after the patients do. Doctors Casatito. Rodriguez is in surgery and can't be reached. You're the senior emergency physician on duty. The weight of responsibility settled on Sarah's shoulders like a physical force. 6 critical patients arriving within minutes, and she would be making the initial triage and treatment decisions that could mean the difference between life and death. Her civilian training had prepared her for this moment, but the military setting added layers of complexity she was still learning to navigate. "What do we know about the casualties?" Sarah asked, her voice steadier than she felt. 4 with severe burns covering 30 to 60% of their bodies, Santos replied, consulting her notes. 2 with suspected blast lung injuries and possible traumatic brain injury. Ages range from 19 to 32. All male, all Navy personnel. Sarah closed her eyes for a moment, running through her training. Burn victims required massive fluid resuscitation and immediate pain management. Blast lung injuries could be deceptive, appearing minor initially before becoming life-threatening. Traumatic brain injuries required constant monitoring and could deteriorate rapidly. Alert the burn unit and request immediate consultation, Sarah instructed. Notify the ICU that we may need multiple beds. Set up all 6 trauma bays and ensure we have adequate supplies for major fluid resuscitation. The next few minutes passed in controlled chaos as the medical team prepared for the incoming casualties. Sarah found herself naturally taking charge, her civilian training kicking in despite the military environment. The nursing staff responded to her instructions without hesitation, their professionalism overriding any lingering doubts about her qualifications. The sound of approaching helicopters filled the air as the first medevac aircraft arrived. Sarah positioned herself at the trauma bay entrance, mentally reviewing protocols and preparing for the decisions ahead. Chief Santos appeared beside her, carrying a clipboard with patient information. The ship's medical officer provided preliminary assessments, Santos said. He's recommending immediate surgery for 2 patients and intensive monitoring for the others. The first stretcher burst through the doors, carried by Navy corpsmen whose uniforms were stained with blood and soot. The patient was a 19-year-old seaman with burns covering 40% of his body. He was conscious but in obvious agony, his young face contorted with pain. Seaman Johnson, 2nd-degree burns to torso and arms, some 3rd-degree areas on his chest, the corpsman reported. Vital signs stable, but he's been asking for his mother. Sarah moved immediately to assess the patient. The burns were severe but appeared to be primarily 2nd-degree, which meant the underlying tissue was still viable. However, the extent of the burns meant massive fluid loss and the potential for infection. "Start 2 large-bore IVs immediately," Sarah ordered. "Begin lactated ringers according to the Parkland formula. I want pain management protocols initiated now." As the nursing team began treatment, the 2nd patient arrived. Petty Officer 3rd Class Williams, 24 years old, was unconscious with suspected blast lung injury. His breathing was labored and Sarah could see the telltale signs of respiratory distress. The cases continued to arrive in rapid succession. Each patient presented unique challenges that required immediate assessment and treatment decisions. Sarah found herself moving between trauma bays, making split-second judgments about priorities and resource allocation. The 3rd patient, Chief Petty Officer Davis, was conscious but had suffered severe burns to his face and neck. The psychological impact of facial burns was significant, particularly for military personnel whose identity was closely tied to their physical appearance and capabilities. Davis kept asking if his face would return to normal, if he would still be able to serve. "Chief Davis, I know you're worried about your appearance," Sarah said gently while examining his injuries. "Right now, my priority is managing your medical needs and preventing complications. We have excellent plastic surgeons here who specialize in burn reconstruction. Will I be able to stay in the Navy, Doc?" Davis asked, his voice hoarse from smoke inhalation. Sarah paused, recognizing the deeper fear behind the question. For career military personnel, medical retirement due to injury represented not just physical disability, but the loss of identity and purpose. "Let's focus on your recovery first," Sarah replied. "The Navy has excellent rehabilitation programs, and medical review boards consider many factors beyond initial injuries. The 4th and 5th patients arrived together, both with blast lung injuries that were more severe than initially reported. Sarah realized she was facing a decision that would test everything she had learned about military medicine. Both patients needed immediate intubation and mechanical ventilation, but the hospital only had one ventilator immediately available in the emergency department. Civilian medical protocols provided clear guidelines for such decisions based primarily on likelihood of survival and potential years of life saved. Military medicine added additional considerations including rank, mission-critical personnel, and the unique bonds between service members. Sarah studied both patients carefully. Seaman Rodriguez was 21 years old with severe blast lung injury but no other apparent trauma. Petty Officer First Class Thompson was 32 with blast lung injury complicated by possible traumatic brain injury. Based purely on medical factors, Rodriguez had a better prognosis, but Thompson was a senior non-commissioned officer with extensive experience and training. Chief Santos appeared at Sarah's shoulder. "Dr. Chen, we need a decision on the ventilator." Sarah took a deep breath, drawing on her training and instincts. Rodriguez gets the ventilator. His lung function is more likely to recover with mechanical support. Thompson shows signs of neurological involvement that could complicate his prognosis regardless of respiratory support. The decision made, Sarah moved quickly to implement treatment protocols. As Rodriguez was intubated and placed on the ventilator, she continued working to stabilize Thompson using manual ventilation techniques and high-flow oxygen. The sixth and final patient, Lieutenant Commander Hayes, was the most senior officer among the casualties. He had refused evacuation initially, staying aboard to coordinate rescue efforts for his injured sailors. By the time he finally allowed himself to be transported, his burns had worsened and he was showing signs of shock. "Commander, I need you to let us treat you now," Sarah said firmly as he attempted to sit up on the stretcher. "Your sailors are being well cared for, and they need you to recover so you can continue leading them." Hayes looked at her with surprise. Most medical personnel, both military and civilian, tended to defer to senior officers even when they were patients. Sarah's direct approach caught his attention. "Who are you, Doctor?" Hayes asked. "I don't recognize your rank insignia. I'm Dr. Chen, and I'm a civilian emergency physician," Sarah replied while examining his burns. "Right now, I'm your doctor, and I need you to follow my medical orders just as your sailors follow your military orders." The lieutenant commander nodded slowly, recognizing the parallel. For the next hour, Sarah moved between the 6 patients, monitoring their conditions and adjusting treatments as needed. The burn unit consultants arrived and began planning surgical interventions. The ICU team prepared to receive the most critical patients. Dr. Walker arrived 45 minutes after the first patient, expecting to find chaos and possibly serious medical errors. Instead, she found a well-organized treatment area with appropriate care being provided to all 6 casualties. Sarah was at the bedside of Seaman Rodriguez, monitoring his ventilator settings and checking his neurological responses. "Status report, Dr. Chen," Walker said quietly. Sarah provided a concise summary of each patient's condition, treatments provided, and current status. Walker moved through the trauma bays, reviewing Sarah's work and checking on the patients. When she returned, her expression showed a mixture of surprise and approval. "Excellent work, Doctor," Walker said. "Your triage decisions were sound, your treatment protocols were appropriate, and you managed to maintain stability in all 6 patients until specialty consultations arrived." "Thank you, Commander Walker," Sarah replied. "I had excellent support from the nursing staff." "Don't minimize your contribution," Walker said firmly. "You were the primary decision-maker during a critical period, and you performed exceptionally well." As the sun rose over Portsmouth Naval Medical Center, 5 of the 6 patients had been stabilized and transferred to appropriate care units. Seaman Rodriguez remained on the ventilator, but was showing signs of improvement. Chief Davis had been taken to surgery for burn debridement. Lieutenant Commander Hayes was in the burn unit receiving specialized care. The exception was Petty Officer Thompson, whose condition had deteriorated despite Sarah's efforts. His blast lung injury was complicated by severe traumatic brain injury that had not been apparent during the initial assessment. He was transferred to the neurosurgical intensive care unit in critical condition. Sarah felt the weight of that outcome heavily. She had made the right medical decision based on the information available, but the uncertainty of Thompson's prognosis troubled her. In civilian medicine, such outcomes were discussed in morbidity and mortality conferences as learning opportunities. In military medicine, they carried additional emotional weight because of the bonds between service members. Dr. Rodriguez appeared as Sarah was completing her documentation. He had been notified of the mass casualty event and had come in early to review the cases. "Dr. Chen, I've reviewed your treatment decisions and patient outcomes," he said. "Your performance was exemplary. The triage choices you made were medically sound, and your resource management was excellent." "Thank you, sir," Sarah replied. "I'm concerned about Petty Officer Thompson's prognosis. His injury was severe regardless of treatment decisions," Rodriguez said. "You cannot save everyone, doctor. What matters is that you made the best decisions possible with the information available." The philosophical discussion was interrupted by Chief Santos, who approached with a clipboard of paperwork requiring Sarah's signature. "Chen, I wanted to tell you that the nursing staff was impressed with your leadership during the incident," Santos said. "You maintained clear communication and appropriate priorities throughout the emergency." As Sarah signed the required documentation, she reflected on the night's events. Her first major test as the senior emergency physician had involved complex medical decisions complicated by military culture and hierarchy. She had drawn on her civilian training while adapting to military protocols and expectations. More importantly, she had begun to understand the deeper responsibilities of military medicine. These patients were not just individuals seeking medical care. They were members of a military family who depended on each other for survival and mission success. Their injuries affected not only their personal lives but their ability to serve and protect others. The experience had changed something fundamental in Sarah's approach to her role at Portsmouth Naval Medical Center. She was no longer just a civilian doctor working in a military facility. She was becoming part of the military medical mission, understanding that her skills and decisions had implications far beyond individual patient outcomes. As she drove home that morning, Sarah realized that the portraits in the hallway no longer intimidated her. She was beginning to understand that military medicine was not about rank or hierarchy. It was about competence, dedication, and the willingness to make difficult decisions under pressure. For the first time since arriving at the facility, she felt like she truly belonged. The weeks following the destroyer incident marked a turning point in Sarah's integration into the military medical community at Portsmouth Naval Medical Center. Word of her performance during the mass casualty event had spread throughout the hospital, and she noticed subtle changes in how other staff members interacted with her. The skeptical glances had been replaced by nods of acknowledgement, and conversations that had previously been polite but distant became more collegial and genuine. Dr. Rodriguez assigned Sarah to increasingly complex cases, testing her abilities while building her confidence in the military medical environment. She began to understand the nuanced differences between treating civilian and military patients, recognizing that successful outcomes required understanding not just medical conditions, but military culture, hierarchy, and the psychological impact of service-related injuries. One particular case in November would cement her reputation as someone who truly understood military patients. Master Sergeant Williams, a 38-year-old Marine with 20 years of service, was brought to the emergency department by his wife after collapsing at home. Initial examination revealed elevated blood pressure, irregular heartbeat, and signs of severe anxiety. His medical history showed no previous cardiac issues, but his service record included multiple deployments to combat zones. Williams was a textbook example of the challenges facing military healthcare providers. He minimized his symptoms, insisted he was fine, and repeatedly asked when he could return to duty. His wife, however, painted a different picture of someone who had been struggling with sleep problems, mood changes, and increasing physical symptoms for months. "Sergeant Williams, I need you to help me understand what you've been experiencing," Sarah said, settling into a chair beside his hospital bed. She had learned that maintaining eye contact and positioning herself at the same level as military patients helped reduce the hierarchical barriers that often interfered with honest communication. "Nothing I can't handle, Doc," Williams replied, his jaw set in the stubborn expression Sarah had come to recognize in career military personnel. "Just need to get back to work. My unit is preparing for deployment, and they need me." Sarah glanced at his wife, who was standing at the foot of the bed with tears in her eyes. Mrs. Williams had clearly been dealing with this situation for months, watching her husband struggle while he refused to acknowledge any problems. "Master Sergeant, I understand your dedication to your unit," Sarah said carefully. "But I'm seeing physical symptoms that suggest your body is sending you some important messages. Help me understand what a typical day looks like for you." Over the next 30 minutes, Sarah gently coaxed information from Williams while conducting a thorough examination. What emerged was a picture of a decorated Marine struggling with the cumulative effects of multiple combat deployments, survivor guilt from losing Marines under his command, and the stress of preparing for another deployment while dealing with unresolved trauma. The physical symptoms Williams was experiencing, elevated blood pressure, heart palpitations, muscle tension, and digestive issues, were manifestations of chronic stress and untreated post-traumatic stress disorder. However, military culture often discouraged seeking help for psychological issues, viewing them as signs of weakness rather than treatable medical conditions. Sarah faced a delicate balance. Williams needed comprehensive treatment for PTSD, but approaching the subject directly would likely cause him to shut down and refuse care. Military personnel often feared that psychological diagnoses would end their careers or prevent deployment with their units. Master Sergeant, your physical examination shows signs that your body has been under significant stress, Sarah said. The symptoms you're experiencing are actually common responses to prolonged exposure to high-stress situations. Many of our most experienced service members deal with similar issues. Williams looked at her suspiciously. Are you saying this is psychological, Doc? Because I can handle stress just fine. I'm saying your body is responding to years of carrying enormous responsibility for other people's lives, Sarah replied. That's not weakness. That's a normal human response to extraordinary circumstances. The question is how we help your body recover so you can continue serving effectively. The approach worked. By framing his symptoms as physical responses to stress rather than psychological weakness, Sarah was able to engage Williams in honest discussion about his experiences and symptoms. She learned about sleepless nights replaying combat situations, hypervigilance that made it difficult to relax even at home, and increasing isolation from family and friends. Dr. Walker, who had been observing Sarah's interaction with Williams, stepped forward. Master Sergeant, Dr. Chen is right. What you're experiencing is common among our most experienced and dedicated service members. We see it regularly, and we have effective treatments that can help you continue your career. The combination of Sarah's civilian perspective and Walker's military authority provided the credibility Williams needed to accept treatment. Over the following weeks, Sarah worked with psychiatrists, social workers, and military chaplains to develop a comprehensive treatment plan that addressed Williams's physical symptoms while providing therapy for his psychological trauma. Williams's case became a model for integrated military health care that other departments began to adopt. Sarah had demonstrated that civilian medical expertise could complement military medicine in ways that improved patient outcomes. More importantly, she had shown that understanding military culture was essential for providing effective care to service members. The success with Master Sergeant Williams led Dr. Rodriguez to assign Sarah to a special project developing protocols for treating service members with combat-related stress injuries. The project required her to work closely with military psychologists, social workers, and chaplains to create comprehensive treatment approaches that respected military culture while addressing both physical and psychological symptoms. December brought another challenge that would test Sarah's growing reputation. A young Navy pilot, Lieutenant Sarah Morrison, was brought to the emergency department after a training accident. Morrison had ejected from her aircraft during a simulated emergency, but the ejection seat had malfunctioned, causing spinal compression and potential neurological damage. The medical aspects of Morrison's case were complex but manageable. The spinal injury required careful evaluation and treatment, but initial assessments suggested good potential for recovery. The psychological impact, however, was devastating. Morrison was one of only a few female pilots in her squadron, and her identity was closely tied to her ability to fly. Will I be able to fly again? Morrison asked repeatedly during her initial assessment. The question carried enormous weight because flying was not just her career, it was her passion and the culmination of years of training and sacrifice. Sarah found herself in the position of providing hope while being honest about uncertainties. Morrison's spinal injury was serious but not necessarily career-ending. However, military aviation had strict medical standards, and even minor residual effects could disqualify her from flight status. Lieutenant Morrison, your injury is serious, but our initial assessment suggests good potential for recovery, Sarah said. The next few days will be crucial for determining the extent of any permanent damage. What I can promise you is that we'll do everything possible to maximize your recovery and explore all options for returning you to flight status. Morrison's case required coordination with neurosurgeons, orthopedic specialists, and aviation medicine physicians. Sarah found herself serving as the primary coordinator, ensuring that all aspects of Morrison's care were aligned with her goal of returning to flying. The treatment process revealed another dimension of military medicine that Sarah had not fully appreciated. Military patients often had support networks within their units that civilian patients lacked. Morrison's squadron commander visited daily, her fellow pilots took turns staying with her, and the military aviation community rallied around one of their own. However, the same military culture that provided support could also create pressure. Morrison felt enormous responsibility to recover quickly and return to duty, fearing that her injury reflected poorly on her abilities as a pilot. She pushed herself too hard in physical therapy and resisted recommendations for psychological counseling to deal with the trauma of the accident. Sarah recognized the pattern from her work with Master Sergeant Williams. Military culture's emphasis on strength and resilience could interfere with healing when patients felt pressure to minimize their injuries or refuse needed care. "Lieutenant Morrison, I want you to think about flying," Sarah said during one of their sessions. "When you're in the cockpit and something goes wrong, what's the most important thing?" "Following emergency procedures exactly as trained," Morrison replied without hesitation. "Right. And if you deviate from those procedures because you're worried about looking weak or incompetent, what happens?" Morrison considered the question. "You could crash and burn." "Exactly. Recovery from a serious injury follows procedures just like flying," Sarah continued. "If you try to rush the process or skip steps because you're worried about how it looks, you could end up with permanent limitations that would definitely end your flying career." The conversation marked a breakthrough in Morrison's treatment. She began following medical recommendations more carefully and accepted counseling to deal with the psychological trauma of the accident. Her recovery progressed steadily, and while questions about her return to flight status remained, her long-term prognosis improved significantly. Sarah's work with Morrison attracted attention from the aviation medicine community. Her approach to treating pilots and aircrew members became a model for other military medical facilities. The combination of medical expertise and understanding of aviation culture produced better outcomes for patients whose careers depended on maintaining peak physical and psychological condition. By the end of her first year at Portsmouth Naval Medical Center, Sarah had established herself as someone who understood military patients in ways that went beyond medical treatment. She had learned to navigate the complex intersection of military culture, medical care, and individual psychology that characterized military medicine. Her reputation extended beyond the hospital. Officers throughout the naval base began requesting her specifically for their medical care. Word spread to other military installations in the region, and Sarah began receiving consultation requests from other military medical facilities. The transformation was remarkable. The young civilian doctor who had arrived nervously at Portsmouth Naval Medical Center had become a respected member of the military medical community. She had not only proven her medical competence, but had demonstrated something more valuable: the ability to understand and connect with military patients in ways that improved their care and outcomes. Dr. Rodriguez noticed the change during Sarah's annual performance review. "Dr. Chen, when we hired you, we hoped you would bring civilian medical expertise to complement our military medicine capabilities," he said. "What you've accomplished exceeds our expectations. You haven't just adapted to military medicine, you've enhanced it." "Thank you, sir," Sarah replied. "I feel like I'm finally understanding what military medicine really means." "Which is?" Sarah thought carefully before responding. "It's about understanding that these patients have dedicated their lives to serving others, and that our medical care needs to honor that service while helping them continue their mission." Rodriguez nodded approvingly. "That's exactly right, and that understanding is what's made you so effective with military patients." As Sarah completed her first year at Portsmouth Naval Medical Center, she reflected on how much she had learned and changed. The nervous young doctor who had worried about fitting in had been replaced by a confident physician who understood her unique role in the military medical community. She was no longer just treating patients. She was caring for service members whose health and recovery had implications far beyond individual outcomes. Their ability to serve, lead, and protect others depended on her medical expertise and understanding of their unique needs and challenges. The portraits in the hospital hallway no longer represented intimidating figures from military history. They reminded Sarah of the long tradition of service and sacrifice she was now part of, even as a civilian. She had found her place in the military medical community, not by becoming something she was not, but by bringing her civilian expertise to serve military patients in ways that honored their service and sacrifice. 18 months after arriving at Portsmouth Naval Medical Center, Sarah had settled into a rhythm that felt natural and purposeful. Her reputation as a physician who truly understood military patients had spread throughout the naval base and beyond. She regularly received consultation requests from other military medical facilities, and her protocols for treating combat stress injuries had been adopted by several hospitals in the military medical system. But nothing could have prepared her for the events that would unfold during the last week of March, when a crisis would test everything she had learned about military medicine and transform her from a respected physician into a legend within the military medical community. The crisis began with what seemed like a routine medical emergency. Commander David Park, a 35-year-old Navy SEAL team leader, was brought to the emergency department following a training accident. Initial reports indicated he had suffered a concussion and possible spinal injury during a high-altitude parachute exercise. Park was conscious but disoriented when he arrived, displaying classic symptoms of traumatic brain injury. However, his military bearing remained intact despite his confusion. He kept asking about the status of his team members and insisting he needed to return to training immediately. "Commander Park, Chen," Sarah said, positioning herself where he could see her clearly. "You've suffered a head injury, and I need to examine you to determine the extent of your injuries." "My team," Park mumbled, struggling to focus his eyes on Sarah. "Need to check on my team. Training exercise isn't complete."
"Your team is fine, Commander," Sarah replied calmly. "Right now, I need you to focus on following my instructions so we can take care of you." The initial examination revealed a severe concussion with signs of increased intracranial pressure.
Park's pupils were unequal, his speech was slurred, and he was having difficulty with coordination and balance. CT scans confirmed Sarah's suspicions. Park had suffered a significant traumatic brain injury that required immediate intervention. What made Park's case particularly complex was his position as a SEAL team leader. Navy SEALs represented the elite of military special operations, and their medical care often involved considerations beyond standard treatment protocols. Park's team was scheduled to deploy on a classified mission within 2 weeks, and his medical status would have significant operational implications. As Sarah worked to stabilize Park's condition, she became aware of unusual activity in the hospital. Senior military officers were arriving, along with medical personnel she didn't recognize. The hospital's administration was clearly treating this case with exceptional priority. Dr. Rodriguez appeared at Sarah's side as she was reviewing Park's latest CT results. "Dr. Chen, this case has attracted attention from very senior levels of command," he said quietly. "Commander Park is not just any SEAL team leader. His unit has been tasked with a mission of national security significance." Sarah nodded, understanding the implications. "What are my parameters for treatment, sir?" "Provide the best possible medical care without consideration for operational schedules," Rodriguez replied. "However, be aware that your medical decisions will have consequences far beyond this patient." The next several hours became a delicate balance of aggressive medical treatment and careful documentation. Park's brain injury was severe enough to require monitoring in the neurosurgical intensive care unit, but not severe enough to require immediate surgery. The critical question was whether he would recover sufficiently to resume his military duties, particularly the demanding requirements of special operations. Sarah found herself consulting with neurosurgeons, military physicians specializing in special operations medicine, and even representatives from Navy's Special Warfare Command. Each group brought different perspectives on Park's treatment and prognosis. The military special operations physicians emphasized the unique physical and cognitive demands placed on SEAL team members. Even minor residual effects from brain injury could be disqualifying for special operations duty. The neurosurgeons focused on optimizing Park's medical recovery regardless of military considerations. The special warfare representatives were concerned about operational timeline and the impact on mission planning. "Dr. Chen, We need your honest assessment of Commander Park's prognosis, said Captain James Morrison, a senior officer from Navy Special Warfare Command. The mission timeline is critical, and we need to know if he'll be medically available. Sarah had learned to be direct in her communications with senior military officers. Captain Morrison, Commander Park has suffered a significant traumatic brain injury. While I'm optimistic about his recovery, it's too early to determine if he'll meet the cognitive and physical standards required for special operations duty. What timeline are we looking at for that determination? Morrison pressed. At least 2 weeks for initial recovery, followed by comprehensive neurological and psychological testing, Sarah replied. Even then, full assessment of his capabilities might take months. The conversation revealed the tension between medical reality and operational requirements that characterized military medicine at the highest levels. Sarah was beginning to understand that her treatment decisions for Commander Park would affect not just his individual recovery, but potentially national security operations. As Park's condition stabilized over the following days, Sarah noticed something unusual in his response to treatment. While his physical symptoms were improving as expected, his cognitive recovery was progressing more rapidly than typical for such severe brain injury. His memory was returning, his speech was clearing, and his coordination was improving significantly. More importantly, Park was demonstrating the psychological resilience that had made him successful in special operations. He was following medical instructions precisely, engaging actively in rehabilitation exercises, and maintaining the mental discipline that characterized elite military personnel. Commander Park, your recovery is progressing well, Sarah told him during one of her daily examinations. However, I need you to understand that brain injuries can have subtle effects that aren't immediately apparent. Even if you feel completely recovered, there may be lingering issues that could affect your performance. Park looked at her intently. Doc, I understand the medical concerns, but I also understand that my team is depending on me, and the mission we're trained for is important. I need to know what I have to do to prove I'm ready. Sarah recognized the challenge Park was presenting. He wasn't asking her to clear him for duty prematurely. He was asking for clear criteria he could work toward. It was exactly the kind of goal-oriented approach that made special operations personnel successful. We'll need comprehensive neurological testing, psychological evaluation, and physical assessment, Sarah explained. But more importantly, you'll need to demonstrate that you can handle complex decision-making under stress without any residual effects from your injury. What happened next would become the foundation of Sarah's legendary reputation. Park asked if she could design a testing protocol that would accurately assess his readiness for special operations duty. He wanted medical evaluation that went beyond standard protocols to truly test his capabilities. Sarah spent the next 2 days consulting with experts in sports medicine, neuropsychology, and military special operations medicine to develop a comprehensive assessment protocol. The testing would simulate the physical and cognitive demands of special operations missions while carefully monitoring Park's neurological function. The assessment took place over 3 days and included complex problem-solving exercises, physical challenges, and simulated mission scenarios. Park performed flawlessly, demonstrating complete recovery of his cognitive and physical capabilities. More importantly, the testing protocol Sarah developed became a model for evaluating special operations personnel recovering from brain injuries. However, the real test came when Park's unit was suddenly ordered to deploy ahead of schedule due to changing operational requirements. His team was needed immediately for a mission that could not be delayed or assigned to another unit. Sarah found herself in the position of making a medical decision that could affect national security. Park had demonstrated excellent recovery and passed all available tests, but conventional medical protocols would recommend additional observation time. The military command needed an immediate decision on his fitness for duty. Dr. Chen, we need your medical clearance for Commander Park, Captain Morrison said during an emergency consultation. The mission timeline has moved up, and we deploy in 18 hours. Sarah had learned to trust her medical instincts and her understanding of military patience. Park had not only recovered from his physical injuries, but had demonstrated the psychological resilience and cognitive sharpness that characterize successful special operations personnel. Commander Park is medically cleared for full duty, Sarah said. His recovery has been complete, and he has demonstrated the capabilities necessary for special operations. The decision proved correct. Park's mission was completed successfully, and his performance showed no residual effects from his brain injury. More importantly, Sarah's assessment protocol became the standard for evaluating special operations personnel recovering from similar injuries. Word of Sarah's work with Commander Park spread rapidly through the military medical community and Special Operations Command. Her ability to develop innovative assessment protocols while understanding the unique requirements of elite military personnel demonstrated a level of expertise that went far beyond conventional emergency medicine. Dr. Rodriguez called Sarah to his office the week after Park's successful mission. "Dr. Chen, I've received calls from medical officers throughout the military system asking about your assessment protocols," he said. "Naval Medical Center San Diego wants to implement your testing procedures, and the Army's Special Operations Command is requesting consultation on similar cases. I'm honored by the interest, sir," Sarah replied. "The protocols were developed specifically for Commander Park's situation, but I think they could be adapted for other special operations personnel." More than that, Rodriguez continued, "You've demonstrated something that military medicine has been trying to achieve for years: the ability to provide medical care that truly understands and supports the operational mission while maintaining the highest medical standards." The success with Commander Park's case established Sarah as the go-to physician for complex cases involving special operations personnel. She began receiving consultation requests from across the military system for cases that required innovative approaches and deep understanding of elite military culture. Her reputation reached the highest levels of military command when she was invited to present her assessment protocols to senior medical officers from all branches of the armed forces. The presentation demonstrated not only her medical expertise but her understanding of how medical decisions affected operational readiness and mission success. "Dr. Chen has accomplished something remarkable," said Rear Admiral Patricia Williams, the Navy's Surgeon General, following Sarah's presentation. "She has shown how civilian medical expertise can enhance military medicine in ways that improve both patient outcomes and operational readiness." The transformation in Sarah's position at Portsmouth Naval Medical Center was complete. She was no longer just a civilian physician working in a military facility. She had become an integral part of the military medical mission. Her office walls now displayed letters of appreciation from Special Operations Commands, Medical Innovations Awards, and photographs with senior military leaders. But the most meaningful recognition came from the patients themselves. Commander Park returned to the emergency department 6 months after his deployment. Not as a patient, but to thank Sarah for her care and to tell her about the mission's success. "Doc, I wanted you to know that everything went perfectly on the deployment," Park said. "No issues with my recovery, and the team performed flawlessly. Your assessment and clearance allowed us to complete a mission that made a real difference." "I'm glad everything worked out, Commander," Sarah replied. "How are you feeling now?" "Better than ever," Park smiled. "But more importantly, word has spread throughout the special operations community about your work. You've earned the respect and trust of some very demanding patients." As Sarah reflected on the case that had transformed her reputation, she realized that her success came from understanding that military medicine was about more than treating individual patients. It was about ensuring that the people who dedicated their lives to protecting others could continue their mission effectively and safely. The nervous young doctor who had arrived at Portsmouth Naval Medical Center had evolved into a physician whose medical decisions affected national security operations. She had not only mastered military medicine, but had enhanced it through innovative approaches that honored both medical science and military culture. 2 years and 3 months after Sarah first walked through the doors of Portsmouth Naval Medical Center, she found herself standing in the base's largest conference room, facing an audience that would have terrified her when she first arrived. The room was filled with the Navy's most senior medical officers, including admirals, commanders from special operations, and representatives from every major military medical facility on the East Coast. The occasion was the annual Military Medicine Excellence Conference, and Sarah had been invited to deliver the keynote presentation on innovative approaches to treating elite military personnel. Her work with Special Operations Forces had gained national attention within military circles, and her protocols were being implemented throughout the armed forces medical system. As she looked out at the sea of uniformed officers, Sarah remembered the anxiety she had felt during her first day at the hospital. The portraits in the hallway that had once intimidated her now felt like colleagues who had welcomed her into their ranks. She was no longer an outsider trying to prove herself. She was a recognized expert in military medicine whose opinions were sought by the highest levels of command. "Ladies and gentlemen, good morning," Sarah began, her voice steady and confident. 3 years ago, I was a civilian emergency physician who thought military medicine was just regular medicine practiced in a military setting. I was wrong. Military medicine requires understanding not just medical science, but the unique culture, psychology, and operational requirements of the people who serve our nation. The presentation covered the evolution of her assessment protocols for special operations personnel, her integrated approach to treating combat stress injuries, and the innovative consultation models she had developed for complex military medical cases. But more than technical details, Sarah spoke about the importance of understanding military patients as individuals whose medical care affected their ability to serve and protect others. During the question and answer session following her presentation, Rear Admiral Patricia Williams, the Navy's Surgeon General, stood to address Sarah directly. Dr. Chen, your work has had impact far beyond Portsmouth Naval Medical Center, Admiral Williams said. Can you tell us about the case that really established your reputation throughout the special operations community? Sarah knew immediately which case Admiral Williams was referencing. It had occurred just 6 months earlier and had become the foundation of her legendary status within elite military circles. The case had begun with a phone call at 3 a.m. on a Saturday morning in September. Master Chief Petty Officer Rodriguez, a Navy SEAL with 22 years of service, had been brought to the emergency department following what appeared to be a heart attack during a training exercise. At 41, Rodriguez was older than most active special operations personnel, but he was considered one of the most experienced and valuable SEAL operators in the Navy. When Sarah arrived at the hospital, she found Rodriguez conscious but in obvious distress. His vital signs indicated cardiac involvement, but something about his presentation didn't match typical heart attack patterns. His pain was severe but localized differently than expected, and his cardiac enzymes were only mildly elevated. More concerning was Rodriguez's psychological state. He was agitated, insisting that his symptoms were minor and demanding to return to his training immediately. His team was preparing for a critical mission, and Rodriguez felt responsible for ensuring their readiness. Master Chief, I understand your concern for your team, Sarah had said during her initial examination, but I'm seeing signs that your body is telling us something important. Help me understand what you've been experiencing lately. What emerged over the next hour was a picture of extraordinary stress and dedication. Rodriguez had been working 18-hour days preparing his team for deployment, sleeping only 3 to 4 hours per night, and dealing with the accumulated physical and psychological toll of 2 decades in special operations. The heart attack was actually a manifestation of severe stress cardiomyopathy, a condition where extreme emotional or physical stress causes temporary weakening of the heart muscle. Rodriguez's heart was literally breaking down from the accumulated stress of his service and his intense dedication to his team's mission. The medical treatment was straightforward, but the psychological and operational implications were complex. Rodriguez needed rest and stress reduction to allow his heart to recover, but his team was depending on his leadership for a mission that had national security implications. Sarah found herself consulting with cardiologists, military psychologists, and Special Operations Command to develop a treatment plan that would optimize Rodriguez's recovery while addressing the operational requirements of his unit. Master Chief Rodriguez, your heart is responding to years of carrying enormous responsibility under extreme stress, Sarah had explained. This isn't weakness. This is what happens to the strongest people when they push beyond normal human limits for extended periods. The breakthrough came when Sarah proposed a novel approach to Rodriguez's treatment. Instead of removing him from his team completely, she developed a modified duty protocol that allowed him to continue mentoring and advising his team while his heart recovered. The plan reduced his physical stress while maintaining his psychological connection to the mission. The protocol required careful coordination with military command and continuous medical monitoring, but it allowed Rodriguez to continue contributing to his team's preparation while his heart muscle recovered from the stress-induced damage. Even more importantly, Sarah recognized that Rodriguez's condition was likely shared by other senior special operations personnel who were dealing with similar levels of accumulated stress. She developed a screening protocol to identify at-risk personnel before they experienced cardiac events. The screening identified 12 other special operations personnel with early signs of stress cardiomyopathy. Early intervention prevented potential cardiac events that could have sidelined critical personnel and affected operational readiness. Rodriguez's team successfully completed their mission, with the Master Chief providing guidance and mentorship throughout their preparation and execution. His heart function returned to normal, and he was able to continue his military career while serving as an advocate for stress management within the special operations community. The case became legendary not just because of the medical innovation, but because of what it represented about understanding military culture and psychology. Sarah had found a way to provide optimal medical care while respecting the psychological needs and operational requirements that defined elite military personnel. As Sarah concluded her description of the Rodriguez case to the conference audience, she noticed several officers in the room nodding with recognition. Word of her innovative approach had spread throughout the military medical community, but many were hearing the details for the first time. Dr. Chen, that case illustrates exactly what makes military medicine unique, Admiral Williams commented. You didn't just treat a medical condition. You understood the human being and the warrior culture that defines our elite personnel. Following the conference presentation, Sarah was approached by numerous senior officers requesting consultation on complex cases at their facilities. Her reputation had evolved from that of a competent emergency physician to a recognized expert in the unique medical needs of elite military personnel. But the moment that would truly cement her legendary status was still to come. 3 weeks after the conference, Sarah was finishing a routine shift in the emergency department when she received an urgent call from Dr. Rodriguez. A delegation of senior officers was en route to the hospital, led by General Marcus Thompson, the commanding general of Marine Corps Forces Pacific. Dr. Chen, I need you to understand that this visit is unprecedented, Rodriguez said. General Thompson specifically requested to meet with you to discuss your work with military personnel. 30 minutes later, Sarah found herself standing at attention as General Thompson entered the emergency department. A Marine Corps legend with 4 stars on his collar, Thompson commanded respect throughout the military. His presence at a Navy medical facility was unusual. His request to meet with a civilian physician was extraordinary. Dr. Chen at ease, General Thompson said, his voice carrying the authority of decades of command. I'm here because your reputation has reached the highest levels of military leadership. Sarah felt her heart rate increase, but her voice remained steady. Thank you for the visit, General. How can I assist you? Doctor, in my 35 years of military service, I have worked with hundreds of military physicians. Thompson began. They have all been competent, dedicated professionals who understand military culture because they lived it. You are different. He paused, studying Sarah with the intensity that had made him legendary among Marines. You are a civilian who has somehow managed to understand military personnel better than most military physicians. Thompson continued. Your innovative approaches to treating our elite personnel have had impact throughout the armed forces. Commanders at every level are requesting your consultation protocols for their medical facilities. Sarah listened intently, unsure where the conversation was heading. Dr. Chen, I have a question for you, Thompson said. How does a civilian emergency physician become someone that Navy SEALs, Marine Force recon operators, and Army Rangers specifically request for their medical care? Sarah considered the question carefully. General Thompson, I think it's because I learned to see military patients not as soldiers, sailors, or Marines with medical problems, but as human beings whose dedication to service creates unique medical and psychological challenges. My job is to understand those challenges and develop care approaches that honor their service while optimizing their health. General Thompson nodded slowly. That's exactly right, Doctor. And that understanding has made you legendary within our community. He turned to address the assembled medical staff who had gathered to witness this unprecedented visit. Ladies and gentlemen, Dr. Sarah Chen represents the best of what military medicine can achieve when civilian expertise is combined with deep understanding of military culture, Thompson announced. Her work has enhanced the operational readiness of our most elite personnel while providing them with medical care that respects their dedication and sacrifice. Thompson faced Sarah C. again. Chen, I am here to formally recognize your contributions to military medicine and to request your assistance in developing medical protocols for elite units throughout the Pacific Command. The general reached into his uniform and pulled out a commendation certificate bearing the seal of Marine Corps Forces Pacific. This citation recognizes Dr. Sarah Chen as an honorary member of the Marine Corps Forces Pacific Medical Community, in recognition of her extraordinary contributions to the medical care of elite military personnel. Thompson read aloud. Dr. Chen has demonstrated that true understanding of military culture transcends uniform and rank, and has enhanced the operational readiness of Special Operations Forces throughout the armed forces. As General Thompson presented the citation to Sarah, the assembled medical staff broke into spontaneous applause. Dr. Rodriguez and Commander Walker were both smiling with obvious pride, and Chief Santos had tears in her eyes. General Thompson, I am deeply honored by this recognition, Sarah said, accepting the certificate. Serving the people who dedicate their lives to protecting others has been the greatest privilege of my medical career. Doctor, you have earned the respect and trust of some of the most demanding patients in the world. Thompson replied. Navy SEALs, Marine Force recon operators, and Army Rangers don't give their trust easily. The fact that they specifically request your care speaks to something far beyond medical competence. As the general and his delegation prepared to leave, Thompson spoke privately with Sarah. Dr. Chen, your legend has spread throughout the military community, he said quietly. Officers at every level know your name and your reputation. You have become what we call a force multiplier. Someone whose individual contributions have impact far beyond their immediate role. Sarah felt the weight of the recognition and the responsibility it carried. General, I hope I can continue to live up to that reputation. Doctor, legends aren't made by single events. Thompson replied. They're built through consistent excellence, innovative thinking, and dedication to service. You have demonstrated all three. As Sarah watched General Thompson's convoy leave the Naval Medical Center, she reflected on the incredible journey that had brought her to this moment. The nervous young civilian physician who had worried about fitting into military culture had become a recognized expert whose innovations were being implemented throughout the armed forces medical system. Her office walls now displayed commendations from every branch of the armed forces, letters of appreciation from special operations commands around the world, and photographs with senior military leaders. But more meaningful were the thank you notes from patients whose lives and careers had been enhanced by her care. Dr. Rodriguez appeared at her side as she watched the convoy disappear. Dr. Chen, when we hired you, we hoped you would bring civilian medical expertise to complement our military medicine, he said. What you've accomplished exceeds our wildest expectations. You haven't just adapted to military medicine, you've elevated it. Sarah smiled, thinking about the portraits in the hospital hallway that had once intimidated her. Sir, I think I finally understand what those portraits represent, she said. They're not about rank or hierarchy. They represent people who dedicated themselves to serving others and who found ways to excel in that service. That's exactly right, Doctor. And now your portrait belongs among them. About history. 3 months later, Dr. Sarah Chen's official portrait was unveiled in the main hallway of Portsmouth Naval Medical Center. She was the first civilian physician to be so honored, and her portrait bore a simple inscription: Dr. Sarah Chen, physician, innovator, legend. But the real measure of her legend was not in official recognition or formal ceremonies. It was in the phone calls from special operations units requesting her consultation, the medical protocols bearing her name that were saving lives throughout the military medical system, and the young military physicians who sought her mentorship to learn how to truly understand and serve the warriors who protected their nation. Sarah had achieved something remarkable. She had become a legend not through military service, but through service to military personnel. Her civilian perspective had enhanced military medicine in ways that honored both medical science and warrior culture, creating innovations that would benefit military personnel for generations to come.